Welcome to this session of the Vanderbilt Eye Institute's Audiovisual Retina Atlas. In this session, we will continue on with central retinal artery occlusions and specifically talk about the various clinical appearances. First, however, we'll do a quick review of the first session and then move on to the topic of this talk. Central retinal artery occlusions are one of the true emergencies in ophthalmology, not only for the eye, but also systemically. They need to be treated as one would treat an acute stroke. Timely referrals and treatment can affect the patient's long-term general health. Also, as an ophthalmologist, you also must rule out giant cell arteritis, as the patient may lose the vision in the second eye in just a matter of hours. The first time you see the patient, they will generally be describing a sudden, painless loss of vision. Now, if they have giant cell arteritis, they may have the temple pain, jaw pain, etc., but we're not talking about that in this particular session. There also should be an afferent pupillary defect. Now, classically, you're taught the swinging flashlight test, where you take a muscle light and swing the light back and forth between the two eyes, trying to find the afferent defect. The method that I have found to be the most sensitive, at least in my hands, is to use a direct ophthalmoscope and look at the movement of the pupil based on the red reflex. Take the direct ophthalmoscope, get about a meter from the patient, put the dial of the ophthalmoscope on a green 2 or a +2. That'll get the pupil in focus, and then swing the flashlight back and forth. You can see subtle movements in the change of the diameter of the red reflex much easier than you can with the flashlight, and trying to look at the movement of a brown iris on a dark pupil, that can be difficult. So I use the direct ophthalmoscope. At the same time, you can also get light sensitivity. You can go to the good eye and say, okay, if this is 100 watts of power, or if you gave me $1 for this, what would it be in the other eye? And you can quantify the light sensitivity in the poor eye. Now, I grayed out the cream-colored look to the retina and the cherry red spot, because if you find a patient early, they may not have these signs quite yet. On initial presentation, the vision may vary from 20/20 to hand motion in someone who has a central retinal artery occlusion. If the patient has an intact ciliary retinal artery, there may be an island of good vision centrally, but the rest of the vision is very cloudy. Some studies have shown that if there's a history of antecedent amaurosis fugax, there's a higher incidence of subsequent strokes. If the vision is no light perception, be aware of involvement of the posterior ciliary artery system as well, and therefore the risk of giant cell arteritis is very high. That is something that you really must rule out as quickly as you can. Now, you don't have to send everybody with a central retinal artery occlusion to the emergency department. If the artery occlusion is several days old to a week old, you can alert the primary care doctor and they can coordinate all of the care. Now, you don't want to wait 2-3 weeks, but you don't have to send to the emergency department. However, if it is an acute occlusion within a day or so, you do want to do that. Now, some of you may be working in an academic center where they have a stroke team on call. Other of you may be working in a more of a rural setting where the team is not quite as up on and aware of what a central artery occlusion is, and they may need some guidance from you as to what to do. So if you do send to the ED department, notify them that the stroke team should be called in as well. Before you do that, always check the blood pressure in your office and act accordingly. That you really, really do need to do. Then if you do send to the lab, tell them you want a stat CBC, Westergren citrate, and a C-reactive protein. That should be automatic even before they call the stroke team, so they can start on the workup immediately. And again, if a smaller ED department is not sure exactly what to get, you do want to get a carotid ultrasound at minimum, but you really probably do want to get an MRA or a CTA of the head and neck to make sure they do not have any carotid occlusive disease, and also look for other central problems such as cerebral hemorrhaging or other vascular occlusions. Okay, now that we've covered what to do and tell the PCP and or tell the emergency department and when to go, we will proceed to the clinical findings. The classic CRAO has a cream-colored macula and a cherry red spot. There are many variations in the presentation depending on the timing and the amount of occlusion. Has the artery opened up since they first had the occlusion? Is the cilioretinal artery occluded, or has it been spared? So, first a word on the cherry red spot. The reason for the cherry red spot in the center of the macula is that the internuclear layer in the macula and the ganglion cell layer are not present over the fovea. It is these two layers that become edematous and therefore white in a central retinal artery occlusion. So the fovea is not edematous because it does not get swollen, and you can see the RPE and the choroid through non-swollen tissue, and that is why it is red. Also, the fovea gets its blood supply from the choroid capillaris, and that is why the tissue that's in the fovea does not get swollen itself. This is a classic appearance of a central retinal artery occlusion with the whitening of the macula, loss of choroidal markings, and the cherry red spot. This is a 64-year-old woman who's had blurred vision in the left eye for only 1.5 hours. Her vision was hand motion. The nerve is pink and healthy. There's no swelling of the nerve. I could really not see a plaque at this time, but you can definitely see the other positive physical findings. This is a 79-year-old gentleman with 3 days decreased vision in the right eye. The vision was 2400. He had a history of diabetes, hypertension, coronary artery disease, and he previously had had a left carotid endarterectomy. At this time, his carotids and the cardiac echo were normal. Now, clinically, note the mild and diffuse interretinal edema and the cherry red spot. Not quite as prominent as the last one, but it is definitely there. He also has some mild hemorrhages scattered about the macula as well. This cherry red spot is a bit more subtle than the first examples because of the pale fundus. But again, if you look closely, you do not see the expected choroidal markings, and the fovea is indeed a bit more red than you would expect. Also, note some cotton wool spots from the swelling of the nerve fiber layer. These can be seen just off the nerve supratemporally and along the infratemporal arcade. Here is another example of someone with a central retinal artery occlusion. However, the area in the papillomacular bundle is quite red, and you can also see a very prominent cherry red spot. The nasal retina is normal because the cilioretinal artery is still perfused. It's just the rest of the macula is very edematous from hypoxia. This is the fluorescein angiogram of that patient, and you can see very prominently at the 38-second mark that the entire capillary system in the papillomacular bundle is intact because the cilioretinal artery and also the vein are intact, full, and functioning properly. And you can see that all of the retinal vessels are not filling at this time. This patient has just the opposite phenomenon. He has good vision, but noticed a paracentral blind spot the day before. The macula and the fovea have a good reflex, but the papillomacular bundle is white, secondary to it being edematous. This is because he has a ciliary retinal artery occlusion. Because the ciliary retinal artery arises from the short posterior ciliary artery system, if a patient has this appearance, you must be very aware that there's a high risk of giant cell arteritis. The fluorescein angiogram on the right side shows filling of the arteries. There's normal laminar flow in the major retinal blood vessels, but the ciliary retinal artery is shut down. If you look closely, you can see the distal ciliary retinal artery is filled. This is not because we missed the dye coming in from the nerve, but this is an example of backfilling. The blood has gone into this area by the central artery, and just hydrostatic pressure is backfilling the peripheral area of the ciliary retinal artery. Now let's move on to the retinal vessels and some of the clinical findings you can find in someone with a central artery occlusion. The various things you want to look for are boxcaring, occluded vessels, as well as Holland-Horst plaques. This patient has suffered a central retinal artery occlusion, and you can see the very edematous central macula and the cherry red spot. The blue arrows point to the boxcaring in the venous system. Now you can see boxcaring both in the arterial and the venous system. And you will find that in this area, you can actually see rouleau of the red blood cells just very slowly moving more centrally. This is not similar to venous beading that we see in diabetics. The venous beading in diabetics signifies capillary loss. Boxcaring signifies incredibly slow blood flow. Here is another patient, another example, and you can see the boxcaring of the nasal retinal arterial system in this patient, and the blue arrows point that out. Now, this is a very interesting clinical picture. This patient has the artery occlusion and a very prominent cherry red spot and an intact cilio-retinal artery. But there's a white vessel superiorly. Now, first, this looks like it is a vein, but if you follow this patient over the next several months, it actually is an artery. The proximal vessel is larger because that is one area where the artery is more occluded peripherally, and the artery is just more dilated in that area. The white area is not a plaque, but you are seeing the wall of the artery that is not filled. The final physical finding which you want to be looking for are emboli. And you should be able to see emboli in 20 to 40% of patients with central artery occlusions. There are two basic types of emboli. They're either the yellow glistening, which we think are cholesterol, or the large white, which are probably calcific and from the heart valves. There's low degree of agreement between observers whether these emboli are truly cholesterol versus calcific. If, however, there are multiple small emboli, is most likely a shower of cholesterol emboli from the carotids. Now, if you do find emboli, it is important not only for the vision, but also there's a double 9-year mortality rate. Now here's a large embolus, and it is right at the bifurcation of the central retinal artery. It is getting the inferior circulation because you can see the large superior hemianopsia. Now, one reason why you may not be able to see any emboli is they may be stuck just posterior to the lamina cribrosa, and then it truly would be a full central artery and not a hemicentral artery as in this case. Here is another example of a embolus at the nerve head. You can see on the color photograph that the superior macula is white, so you have a pretty good idea it is the superior circulation that is being blocked and not the inferior. Look at the fluorescein angiogram on the right. Now this is taken 3 minutes into the angiogram. Now if you look at the blue arrow, there's some filling of the peripheral artery. The supratemporal vein is filled. Now both filling of the vein and the artery at the 3-minute mark are signs of backfilling like we saw in the ciliary-retinal artery occlusion. There's very, very slow filling of the supratemporal artery, but then it stops. If you look at the vein just to the right, or temporal to the blue arrow, you can see it's rather moth-eaten, and this is a sign of extremely slow blood flow in that area. Supranasally, you can see that the artery is blocked, and there's some backfilling of the vein. That blocked artery is pointed out by the white arrow. And a final example of an embolus is this patient, and you can see the embolus very close to a bifurcation of the supratemporal arteriole. The superior macula is white. The fovea still has a fairly good reflex to it. The fluorescein angiogram at the 26-second mark shows that the proximal portion of the artery is filled, but then at the bifurcation, you can see the one branch going through the superior macula is non-filled. Peripherally, there again is some backfilling. There's a loss of the capillary system in the superior macula and non-filling of the major vessels superiorly. The importance of trying to find the emboli is that you have a better idea of prediction of the future for the particular patient. There is an increased risk of mortality in the subsequent 9 years from 27% in patients without emboli to 56% if you do. The mortality, however, is secondary to cardiac problems rather than from events related to carotid stenosis. So, in summary, in the clinical appearances, generally you will have some macular edema, whitening of the retina, and loss of the choroidal markings. You may or may not have the classic cherry red spot depending on how much edema has occurred. You can have some local whitening if the ciliary-retinal artery is affected, and again, you must rule out GCA if you do find that. The central area may have a normal color if the patient has a ciliary-retinal artery, and that is spared. You again want to look at the attenuation of vessels, looking for boxcarring and plaques. And again, you want to look for emboli. You can then notify the patient's general doctor as well as cardiologist that you are finding these emboli because it increases the mortality over 9 years greatly, and they may want to do some investigative or interventional treatments to try to reduce that rate of mortality.